Hi, everybody. Welcome back to Pelvis Party. My name is Becky Montpetit, and I am the owner of Rochester Local. And if you think you're having deja vu, you'd be correct, because the three of us just filmed another episode of the Pelvis Party, but we're back. And this is a special rapid-fire questions for Dr. Richards' edition of the Pelvis Party.
I love this.
And just for introduction's sake, this is Annie Jurrens. She owns a shop in Plainview called Refill Goods. Dr. Melissa Richards is the Division Chair of Hospital and Surgical Services at Olmsted Medical Center. And today, we're going to rapid fire you with some questions that, maybe we feel embarrassed to ask or maybe are totally off the rocker, but we're going to do it anyway.
To be clear, this is probably like any time I go out with a quorum of more than one other person who has a uterus.
Can't wait.
Parts, yes.
Speaking of uterus, here comes your first question.
So since I still have my ovaries, so I still, all the hormones, all the things,
Yes.
Is there, before I could blame things on my period, right? Be like, oh yeah, it's probably just that time of month. And I feel like if I still have those hormones, I'll still be able to do that. How can I tell that it's like, how can I be tracking that without blood?
Yeah.
Great question. So there are different ways to do this. You can do it like if we want to get really sciencey, we could do labs and we could follow and find and look for progesterone, like rises in a hormone called progesterone. You could do LH kits, ovulation kits. You know how people do ovulation kits to know when to make, try to make a baby. Really watching symptoms is a great way to put it.
I thought you were going to say watching Simpsons.
I mean, I guess if you always
That Bart
knows exactly when. No.
Watching symptoms.
Yes, watching your symptoms. Like I know with my IUD, I don't really get a period at all.
Yeah.
But I know mood-wise, and I know I get my IBS usually kicks in. So there are certain things, other clinical symptoms, other symptoms that I have. Why do I want to like get very frustrated with people?
That's a great way to put it.
What that's also tells me a little bit. I have a lot of patients who ask like, how will I know that I'm in menopause? And so my quick way of telling you, the average age of menopause is between the ages of 51 and 52, and you may not know. You may not know. But symptoms you might notice would be like moodiness, changes in moodiness, I should say. Kind of just a change in your metabolism, how you feel, and dry vagina.
Oh,
Your vagina loves estrogen, and some people will notice when they go through menopause that tissue just gets a little drier, it gets less elastic, and sex can actually, if anything's going in your vagina, it can be more uncomfortable than or uncomfortable than previous. All good reasons to talk to your healthcare provider.
Okay, so tons of follow-up questions.
Yes.
One, let's talk about, we're going back to the ovary, but then I have another question about cervical mucus.
Oh, I feel like Becky really enjoys talking about cervical mucus and learning everything. I
do.
love it.
Yeah.
It's great.
Thanks.
It's wonderful.
Great. So I have an IUD as well, although I still kind of have,
light periods.
A light period, very light period. But I can tell every month. I was like, I ovulated. Is that your Corpus Luteum Cyst? Is that what that is? That like
That can be the idea. That's
because
the idea.
we're going there. We're going to go there, and I'm going to tell this story. It was time to make Evie, who is my daughter. She's turning 10 at the end of next week.
Yes.
But I had that pain.
Yep.
And I called AJ. And I was like, hi, got to come home.
Yep.
And we conceived her.
Yep.
Is that pain? Is that cyst? What is that?
It can be
Middle schmerz?
Yeah, the ovary releasing the egg. It can also be the rupturing of that cyst too. So that cyst that you make needs to rupture or go away.
Yes. Yeah.
So sometimes people feel that cramping and yuckiness when that's rupturing. So might be a little bit different period of time.
Yeah.
But that's the idea, is like mid-cycle.
Yeah.
That pain is that egg being released. But then I think there's this follow-up pain that can happen where it's literally that cyst that was made to release the egg rupturing or going away. So a really common thing that I hear from people is they're like, Dr. Richards, I made a cyst once. I'm like, if you ovulate,
Mhm.
you make a cyst every
Every
month.
month.
Thank you,
Yes.
Becky. Yes, exactly. It's just there are lots of different types of cysts.
Yeah.
Lots of different types of
And
cysts.
mine is so distinct.
Mhm.
It's like bing, bing,
Mhm.
bing. I can tell what
Mhm.
side it's on. I know.
Wow, that is
And it's never like a long it's never like
Mhm.
a day like a day or anything like or even an hour.
Mhm.
It's like a moment and it's like it just feels a little stabby.
Mhm.
And that has happened to me since I
Forever.
don't know, forever.
Mhm.
And
It's
so
so fascinating
isn't that
to me.
crazy?
It's also so fascinating that women are always like, "Oh, that's fine. It's just a little stabby," you know.
It's
And like,
true.
if that were men, you
Right.
know, but
Well,
like women, we put up with a lot of pain.
It's true. But it's like it's almost like I don't realize it or notice it because I've had my period since I was 10, right? And so it's just kind of become part of. But then I think, okay, I'm mid-cycle now. So my next question: cervical mucus.
Mhm.
So if you don't have a uterus and you do not have a cervix,
Yep.
but you still have your ovaries that are producing estrogen,
Mhm.
and we don't think cervical mucus is tied to the estrogen that you produce
The
at certain.
flow. Yep.
Do
all
you
the
still
hormones
get it?
changing.
Do you still have it? And is it absorbed into the body, or does it come out like when you know that you're very fertile?
So we're dealing with two different types of discharge. So there's the cervical mucus discharge. So that's gone. If your cervix is gone, that
You're
is
not
gone.
okay.
So you're not going to have that change in. But those fluxes and hormones can change the vaginal flora.
Okay.
So vaginal flora.
Wow. Okay. Mhm.
So yeah, your discharge can maybe change. Maybe you notice changes in your cervical or not cervical mucus, your vaginal discharge.
Okay.
So yeah, but it's not cervical mucus. It's vaginal.
Vaginal discharge and cervical, two different things.
Two different things.
Gotcha.
Yeah.
That helped answer that question.
Absolutely.
If you have a hysterectomy, do you need pap smears anymore?
Oh, that is a fantastic question. Very, very important question. So typically, no. So you are retired from pap smears, but then you have to
For
watch
real?
your face just drop. But your pap smear is not this like CT scan of your vagina. So a pap smear is screening for cervical cancer. That's what it's screening for.
Yeah.
And pap smear with HPV testing typically. We still recommend people who have a history of precancerous cells on their cervix, specifically what's called CIN2, CIN3, if you got it, to continue screening the top of the vagina because vaginal precancerous cells or even cancer in the vagina can happen. So patients who have a history of what's CIN2 or CIN3, if you've got it, we've talked to you about it, we still will do a pap smear HPV-based testing of the top of the vagina because we know about 4% of patients with CIN2 or 3 can get what's called vein. That's it's similar to CIN2 or 3 abnormal cervical cancer cells of the vagina.
Yeah.
So those people get to hang out with us a bit longer for 25 years actually after that diagnosis of those precancerous cells on their cervix. But typically if you've had a hysterectomy, oftentimes I get to say you're done with cervical cancer screening.
Oh, wow.
But you still should have a great relationship with a healthcare clinician, whether it's an OBGYN or a family med, primary care, internal medicine, whoever you feel comfortable with talking about, am I having issues with pooping or peeing? Am I having concerns with when anything goes into my vagina, it's not comfortable? Do I feel pressure, like prolapse symptoms? And like all of those things we still want to talk about.
Yeah.
That was a long answer.
That was
great.
That was a good question. No, that was
Yes.
a good question.
When I went in for my first appointment with you, you told me about some non-hormonal options that I was shocked to know about.
Right.
Can you tell us a little bit about those again?
Yes, absolutely. So a lot of people, for one reason or another, hormones just don't work well for them, but we use hormonal manipulation to help with periods so often. But non-hormonal options, my go-to is ibuprofen, 600 milligrams every 6 hours for up to 5 days can decrease your bleeding by about 50%. 50%.
When she told me that, I was like, how have I never heard this?
Did you say 3
Before.
ibuprofen
every 6
Every
hours,
6 hours
for up to
5
5 days. Yep.
Starting right with like the onset
First drop
of your
of blood.
system.
Yep, exactly.
50%.
50%.
That's wild.
I usually follow that comment with, but if you're bleeding the ocean, that's still a lot of blood. We cut that in half.
Yeah.
Right.
But that's a great option. There's a medication, I like to call it by its brand name because it sounds prettier, Listita, but the generic name is tranexamic acid.
Oh,
It just sounds better, right?
Yeah.
Exactly. That's a medication you also just take during your periods. It's 3 times a day. It's a prescription medication, but it can make a big difference in decreasing bleeding. There are a couple other newer medications that are coming out too. Those are my 2 big ones that I go to. Oftentimes I'm joining people like they've been on this road for a very long time. So those medications sometimes aren't enough to meet the needs of the patient, but I want to make sure that they know about those options, especially patients who aren't ready to do something that keeps them from getting pregnant. So a patient who's trying to get pregnant, it can be insult to injury that not only did I not get pregnant this month, but once again, I'm bleeding the ocean.
Sure.
So a great option for people who don't want to do something hormonal, don't want to do something permanent, but need to reduce the amount of bleeding they're having.
Sure.
Yeah.
Can you explain again what ablation is? Because you had told that before, but I don't remember what that entails.
Absolutely. So endometrial ablation, we do a very specific one at OMC. There's lots of different ones that you can do, but the idea is you're burning or ablating the lining of the uterus. This is where, follow me here. So think of your yard and the grass. And like your IUDs and your hormonal options, they keep the grass really short, right? So then when you mow the yard, there isn't much there, right? Endometrial ablation, you light it on fire. So the grass is burned, essentially. So an endometrial ablation is a 2-minute procedure, really slick, where it burns or ablates the lining of the uterus that you normally build and shed every month. An endometrial ablation is an awesome option for a very, in my opinion, specific patient population because you're in a race with menopause because that tissue will grow back eventually. So typically what I'll say is after age 45, regular heavy periods because it's not going to help with the timing and you're going to expect a 75 to 99% reduction in bleeding. You have to have a solid form of birth control, typically permanent sterilization. Either you're having sex with someone who's had a vasectomy or you've had a tubal ligation or a permanent sterilization procedure because it can be devastating if you get pregnant after an endometrial ablation. And the idea is it ablates, burns the lining of the uterus, light bleeding every month or no bleeding. I love that procedure. I think it's a great non-hormonal option. I usually kind of pair it up with the IUD. But when I have a under 45, especially after 40 or under 40 patient, it's not always the best option for them because typically they will have bleeding down the road or issues with pain actually after that procedure. And if you have those issues, we need to do a hysterectomy. But it's a great procedure for the right patient population.
What is the process for a tubal ligation?
Ligation? Yeah, very well.
Yeah. What is that?
Yes.
Or what does that entail?
Great. So that's a form of permanent sterilization. So permanent sterilization prevents you from being pregnant. It should be considered permanent. So the neat thing is we have a lot of long-acting reversible birth controls that don't require you to take a pill every month. But if you've decided like, I am done, I want something that is permanent, what we typically do now is remove all of the fallopian tube because remember the fallopian tube is the highway where the egg and sperm meet exactly when they're rolling around there.
Not bulbous straws.
Yes, not bulbous straws. Nope. So when I counsel a patient on permanent sterilization, my method of performing permanent sterilization for a non-pregnant patient, we'll get to it in a hot second, would be laparoscopically. You can also do it vaginally. That's an option, but I typically do single port laparoscopy. So I make one incision in the belly button, and then I'm able to I really try to remove all of the fallopian tubes on both sides to reduce the risk of getting pregnant because if you don't want to get pregnant, there's that risk of getting pregnant. If you do get pregnant, you're at increased risk for an ectopic pregnancy also because I've damaged the fallopian tubes. As long as I remove about 1 inch from each side of the fallopian tubes or put little clips on the fallopian tubes, I have provided permanent sterilization or a tubal ligation. when we talk about tying tubes, we're really not tying anything.
Interesting.
No, there's no like tying. I'm not in there like loop
Tying
loop
a
and wrap it
ball.
around.
Okay.
Yes.
That has definitely been what's in my
No,
head.
there's
though.
not.
No,
Yeah.
exactly. No. There's lots of different ways to do a tubal ligation. In my personal opinion, the best way to provide permanent sterilization is to remove as much of the fallopian tube as humanly possible. We'll remove fallopian tubes during a cesarean section. It adds about maybe 5 minutes to the surgery at most. Yep. So we provide permanent sterilization at that time. And then another time would, if you've had a vaginal delivery, this is kind of cool. So after a vaginal delivery, we can make that same incision, one incision in the belly button. And because the uterus is big right after having a baby, the belly button, the top of the belly button is typically up by on top of the uterus is up by your belly button. So we're able to use that to our advantage, make once again a very tiny incision.
Yeah.
And you go off to sleep, La La Land, with our anesthesia partners, and then you'll be laying flat, and then we'll actually kind of airplane you a little bit while you're laying flat.
Yeah.
And that'll make the uterus slide over, and then I can see your fallopian tube through my very tiny incision, and then remove your fallopian tube as much as I can. And then I'll airplane you, and then your uterus slides over, and then I remove the other portion of the other side.
Interesting.
Isn't that cool? Tiny holes.
This is very fascinating. For a second, I've been so riveted, I forgot that I'm hosting Pelvis Party. I have just been like staring. And it has been so fascinating hearing all of the things that our body does. I swear women's bodies are phenomenal, and knowing all of these things and that my fallopian tubes are not boba straws, like it's just, it makes me feel really empowered. So again, thank you so much for letting us pepper you with all of these questions. Great questions, Annie.
Oh, thank
We're
you.
just very curious people. And you're so willing. Thank you for sharing all your information. So if you've liked what you've seen today, head to rochesterlocal.com/pelvisparty for all of our episodes. And thanks so much for joining us.